3, but you guys should be up to your reading on week 4. So we're going to start off the class, and I'm going to start with a video. So we talked about last week, the topic was rural healthcare and all the impacts of that on nursing, right? So we're going to start with a video tonight on that. And then we're going to do like a little quiz, but you're not going to get quizzed on it. We'll do it together. So it's like a quiz together. And any quick questions for the good of the group at this point? No, everybody's good-ish.
I have one more question.
Sure.
The CJ Sim, is it due on Sunday? It didn't have a due date.
Okay.
Some
of the assignments I can't alter. They're like, they won't let me put a due date. So if that's the case, well, everything's always due on Sundays except our discussions. Okay, so just so everybody knows for that. It looks like I'm working on your papers as well. All right, well, I'm going to start the video. Our class is very light tonight. Does anyone know why? I asked at the beginning, but nobody seems to know. No. Alrighty, well, you guys will all get full credit for being here, so that's a good thing. Alrighty, so we're going to start with a rural healthcare video to start the class tonight, okay? This was our chapters from last week, so let's take a look at that. Oops, don't look at that. Can everybody see the video? It didn't start yet, but I just want to make sure.
Yeah, I could see it.
Okay, thanks.
Farm workers face major challenges accessing health care, but a group in southeastern Arizona has a unique solution that appears to be working. From the Cronkite School of Journalism at Arizona State University, Annika Abbott reports.
Bend, pluck, place, repeat. For hours a day, workers at Nature Sweet Farms in southeast Arizona pick tomatoes. It's work that requires strength, skill, and good health. Public health expert Jill Guernsey-Desapian says farm work often causes muscle and back issues.
Everything for harvesting crops, for packaging them, et cetera and stuff, it is built to make it happen fast. It's not built to protect the body of the workers.
The National Center for Farm Worker Health says the top 3 things farm workers suffer from are obesity, hypertension, and diabetes. Workers like Dylan Valenzuela do what they can to get ready for the day.
When we enter, first we have to exercise, stretch out, then we put all the protective clothes on for the greenhouse.
Even though they prepare for the work, some farm workers struggle to maintain their own health.
400 people work in this tomato plant. The majority of them work here in the greenhouses, and almost 95% of them speak Spanish primarily.
Language is one barrier to health care, access is another, says Gail Emmerich, Executive Director of the Southeast Arizona Area Health Education Center, or CHEC.
Particularly precarious with farm workers is the type of labor they're involved in, if it's shift work versus ongoing or formal employment. And so some people might have health insurance and health coverage and others may not.
The National Center for Farm Worker Health says almost 53% of farm workers across the country are uninsured. Even some with health insurance have limited access. The ratio of people to doctors in rural areas is 2,500 to 1.
It's not saying necessarily that we don't have enough health professionals. It's saying that they're not distributed well throughout the country.
Here in Winchester Heights, an unincorporated Latino neighborhood just 10 minutes from the farm, there are no doctors. The closest town with a medical facility is 20 minutes away. Enter the Southeast Arizona Area Health Education Center, whose goal is to help residents in rural areas gain access to health care. In Winchester Heights, they helped build a community center where public health interns train resident volunteers, known as Promotoras de Salud. After receiving training, healthcare workers like Aida Dominguez go door to door in Winchester Heights to teach their neighbors about better health, like nutrition and sun protection.
Y entonces ella dijo, estoy agradecida porque.
And then she told me, I am so grateful because I didn't know, but now I know that you have to wear a hat.
Latino farm workers say the community center and health workers have made an impact on their health. Having promotoras who speak their own language and come from their own community make a difference.
Es importante para tener como un ambiente social.
It's important to have a social environment and also to be able to help the children, the youth, the adults, the elders, so we will be united.
Along with healthcare, the health education group is now also teaching residents how to run their own nonprofit. They plan to turn the community center over to the people in Winchester Heights next year. For the PBS NewsHour, I'm Annika Abbott with Cronkite News in Winchester Heights, Arizona.
Challenges accessing
All right, so we're going to stop.
But a group in South.
So this really covered this video. I liked it and I share it with you because I felt like it really covered everything that we're going to look at with rural healthcare. What were some things? What were your first impressions of the video? What were things you saw or things that you heard that might be helpful in community nursing?
The lady
There is in a hospital. Oh, sorry. Go ahead.
The lady not knowing to wear a hat.
Yeah, so something that like we consider sometimes basic, you know, that we would know to do. She didn't even think about wearing a hat. Good point. What else? Sonia, what were you going to say?
The fact that there's no healthcare, no hospitals nearby in the area. So if something was to happen, they're kind of stuck. They would need to know.
Yeah. And what do you think that does long term to people?
And I would say kind of deters you from seeking healthcare at all. Just makes you not seek it out when you really need it.
Right, good. And so what we see also with rural healthcare is we see an increase in diseases, and that is because sometimes they're not getting screened. You know, they're not around doctors. It's very hard to get people to work in rural communities, you know, because unless that's your background, then you don't really want to be there. So, you know, these are things that we look at. So we're going to take a look at a PowerPoint that is going to review our concepts that we're going over tonight. And I'm going to ask that you guys, I was going to have you do it as groups, but I think what we'll do is we'll do it as a whole class. Okay. So first thing we look at were what are some pros and cons of rural healthcare and nursing? What were some things that you guys read about or heard about? What were some, we talked about cons. There's not a lot going on there. There's not a lot of healthcare facilities. What else are some things about rural healthcare that you think is important?
Transportation.
Good. They have a hard time getting there.
Some don't have citizenship, maybe, and they're afraid.
Okay, if they don't have citizenship, what else may they not have?
Insurance.
So we have to worry about insurance for this group of patients. What else?
The way they live.
Okay, tell me a little bit more.
They may all live cramped up inside like one whole area, in bunk beds or something like that inside a little small room.
Right. And you don't really know what the living conditions are unless you see them, right? So a best thing for us to do would be to go out into the field and go to the homes. There's something else that we see with farm workers all the time, and they're getting something. I'm going to show you a picture and maybe you guys can help me with that and you'll figure out what I'm talking about. There's something in the rural communities that we see with our migrant workers quite a bit. And that is, think about what are they exposed to all the time?
Pesticides.
Good. That's our big one, is going to be our pesticides. So I show you this picture.
I can't hear you.
I think she muted herself. I can't hear anything either.
Yeah, I think she did most of it. Seems to be on. Professor, you're muted.
We can't hear you.
Muted.
Thank you. I'm muted. No wonder you couldn't hear me. All right. So, so pesticides, think about it. They're like spraying all over the lands, you know, and we do our different preventions. We do primary. So what are some things we could do for primary prevention for our pesticides?
Make sure they have the proper equipment so they won't be too exposed to it.
All right. So we're going to prevent the exposure. Who are we going to teach primary to? We're going to teach it to the farm workers, or we're going to teach it to the people that own the farms?
People who owns the farms.
Go ahead, Tanya. Sorry.
To the farm workers. Well, really to both, but primarily to the farm workers because they're the ones out there actually exposed to the pesticides.
Yeah, so you really want to teach the farmers, and then they will be able to implement that because the workers aren't going to be able to do much for prevention on their own, right? You can teach them how to use protective equipment. You can screen them. But when we're teaching, we're trying to get equipment in there that will, and let the farmers know how dangerous the pesticides are, right? So we're going to think about those kind of teachings and preventions when we look at that. So that is something else that we look at with rural healthcare. What do we know about small communities that's different as a whole than cities? What do we even know about the people that live there?
They know everybody.
Good. There's going to be a lot of that. I know what goes on. So what ends up happening in our rural communities is a lot of lack of disclosure. So they're not going to report things like mental illness. They're not going to be reporting abuse because they're afraid everybody's going to know it if they report it. So something that we look at to be careful with, okay? Those kind of things. They all kind of know each other. And so you get a lot less reporting that way. So that's concerning as well for our group. When we take a look at, we're going to go back to, oops, not this PowerPoint. Well, I'll do that here. We look at our chronic illnesses among our rural community. So a decrease in their overall status, they're less likely to participate in activities like during their free time. They have decreased compliance with our safety precautions, like the woman spoke and said she didn't even know to wear a hat. So sometimes it's lack of education. We know that chronic disease is going to be more prevalent among our rural clients because, as we talked about, they don't get the kind of healthcare as often as they need to. All right. So any questions on the rural community?
I think some people can't get in because I couldn't, then I got out, came back in, but there's still some people waiting that can't get in.
Where are they waiting?
In the waiting room, in your waiting room or something.
I don't see anybody in the wait room. Isn't that weird?
So I had the same problem. I had to look at the Zoom schedules you guys had for the exams to get your Zoom login ID because your Zoom login ID is not in the announcements anymore. So I was putting in from the email that you sent us with the professor that we covered with the week before last. And that's probably where they are because that's where I was before I logged into your
All right,
class.
let me send a quick email then to everybody.
I was over there too. And then I think I got one from a weekly thing or something. And then now I ended up here.
Okay, so let me just send an email to the class. And do you guys want me to put the Zoom in our weekly announcements? I don't usually, only because just because it's not something I do, but I can if that's helpful. Is that helpful?
You don't have to do it every week, but that one that you'd be sending now would be great just to leave it.
Yeah, I'm sending now the meeting ID right now to everybody.
Thank you.
Thanks for letting me know. I was wondering where everybody was. All right, so anyway, any questions on rural healthcare? No? Okay, that's a big topic that we covered on week 3. Migrant workers, we talked about that. And so we're going to do a little bit more on another PowerPoint here. Hold on. All right, so I'm just sending our Zoom ID to everybody. And it looks like 2 more joined. Okay, so anyway, that was our first topic. We're going to take a look back at our little test or quiz that I told you we were looking at. So we did our pros and cons here. Oops. And then we talked about healthcare risks. What do you think is going to be a problem with women and children in our rural healthcare?
Immunizations.
Okay. Why do you think of immunizations? Maybe because they don't go. Good. What else is going to be a concern?
Pregnant women may not get the prenatal care that they need. And depending on how far the facility is, they may be at risk for a home birth due to not getting to a hospital on time when going into labor.
Good. And we think about our preterms, right? Preterm labor, because they're not going to get as far, you know, if you're in a city, you're going to have hospitals that are within 5-10 minutes, you can get there. Whereas if you're contracting and you're 20 something weeks, you know, you really want to get to a facility quickly. How about kids? What do we worry about with kids in these rural areas?
Not going to checkups regularly.
Yep. And so what are we going to see then?
Poor nutrition and development.
Yeah, you could have poor nutrition, you could have obesity. What else are you going to have? Remember, in our rural areas, we talked about something that we worry about. Kids are being exposed to this as well. What was that we saw sprayed everywhere?
Pesticides.
Good.
Yeah.
So pesticides on kids, you know, you got to think about that impact, because their little lungs are not able to function as well as adult lungs, particularly when they're being exposed to those pesticides, right? Mental health care, what do we think about that in our rural areas?
Undiagnosed.
There's not a lot of options for help.
Yep, there's not a lot. So what's that going to do to our mental health population?
They're not going to be able to get the right help because they're going to be afraid to talk to anybody else.
Good. So that plays the 2 parts that we talked about, that they're afraid to say things and they don't have the mental health care. So therefore, we're going to see a harder mental health outcome, and particularly women and children. We see a high risk of those, as we talked about. I think we've covered this. What's our biggest barriers? Transportation, availability, lack of honesty, not lack of honesty, lack of ability to communicate. Maybe there's language barriers, right? What would be a biggest concern we could think of when caring for those who live in the rural area?
Insurance.
Right, that would definitely be a concern. Because if they don't have insurance, they're certainly not going to get care. What else is going to be another big concern we worry about?
Was it confidentiality?
Confidentiality is always going to be a concern. Good. And we spoke about confidentiality, and they're afraid to disclose stuff because everybody knows everybody. What else are we going to have as another big concern?
Maybe people not following through with their treatment plans due to not having proper education, or with the hospitals being so far away, they may not be able to, when they leave the facility, they may forget what the provider told them and then don't go back because it's so far to ask them what they said.
Okay, so what are we going to make sure we give to them when they leave?
Education on ways to get transportation, or
we're going to do a lot of handouts with this group. The other thing to remember is our language barriers here. So we have to be very careful. We're going to try to make sure when we're in our rural areas that we have English, Spanish, and whatever language is spoken, right? Because that's going to be a hard thing. If you hand them a piece of paper in English and they don't speak English, that's not going to do them very well, right? All right, so good. We talked about prevention levels with our pesticides. We move into another vulnerable group. It's our homelessness. What are the effects of homelessness on health?
their environment.
Okay, what do we see on the health and well-being of our homeless?
A lot of them suffer with mental illness.
Iron deficiencies and nutrition.
For sure, nutrition.
Like if they get hurt or whatever, not going to get help and then causing it to become worse.
When we look at our rural population and our homeless population, we tend to see a lot of similarities here. What do you think they have an increase in with their health? Acute or chronic?
Chronic.
Yep, you're going to see an increase in chronic diseases with our homeless. We also know, where do they get healthcare? Anybody work in the ER?
Yep, in emergency.
Yep, Tiffany, you see them there, correct?
I was going to say that they kind of use the ER as like a primary care, or like if it's cold outside, they'll come in for a snack or a blanket or something. And
yeah, good. And they come in there, when they come in there, a lot of times, like you said, Kimberly, they're not necessarily coming in for medical care. They're coming in for comfort care, right? So we have to be sensitive to that. They have an increase in chronic illnesses. Their ability and to get medications for chronic illness is going to be very limited. They don't have access. There's shelters. What else do we see an increase with our homeless? What kind of disease processes do we see an increase in the homeless?
In my experience with clinical, there's a lot of contagious diseases because they usually live really close to one another and don't have the knowledge or the education on how to prevent that.
Good. And in addition to that, it goes hand in hand with that. They also tend to use share medication techniques, meaning they'll use IV drug use and then they'll share their needles. I don't know if anybody's seen, but what we've done as a society is now there's places where you can have them dispose of the needles and then you give them clean ones. People always don't understand why you're giving them clean ones, but the choice is they're going to use the needles anyway, right? So we give them the clean ones so that they are less exposed to our infectious diseases, right? Like our hepatitis or HIVs, that kind of stuff. Anybody work with the homeless population?
Yep.
Other than Kimberly, she said she works in the ER. Delora, where do you work with them?
I work in the infusion center.
Okay.
Where we do like cancer patients and stuff. So we have a big resource that we have for them. And we have a couple of the homeless shelters that we also work with. So to make sure that they get their medications and stuff and hydration and food and stuff.
And do you see them coming back to the shelters, or do you see a lot of lack of follow through?
They have a social worker that's there at the actual shelters that we deal with, and they make sure that they have a place every time they finish their treatment, that they come back and actually be able to lay down and get some more hydration and get something to eat, make sure they take their medications. They know what time they have to be back or they won't be able to get back in, which is going to be bad on them. So they understand the consequences, but they have been doing pretty good.
Good.
The centers have been doing pretty good.
Yeah, so that's a big concern with our homeless population. We can reach out to them and provide the shelters and provide the needle exchanges and stuff like that, but they have to A, remember, and B, want to return to the facility. So, you know, a lot of times you'll see that they don't get the care when it might be available. But think about homeless in a rural community. What do you think about their health care?
They're not getting any at all.
Yeah. The availability is so slim there that you're going to have a really hard time with our homeless population in our rural community. So I want you guys to do some thinking about them. This is one of our vulnerable populations, right? Our homeless. And what we know about them is that they have higher rates of what? All our vulnerable populations have higher rates of what?
Mortality.
Yep. And disease process. They have higher rates of disease process. And they also are going to be economically, what do we see with our vulnerable populations? What's a concern with them economically?
Poverty.
What do we know about education and poverty?
Lack of education.
right? So this is what's going to make our vulnerable populations vulnerable. You guys will work on that project for week 9. It's an individual project where you're going to find a vulnerable population in your community, and you're going to do a lot of research on them and see what are the resources, what can we do as nurses to make their lives a little easier and help them out quite a bit. And how many of us live in a rural community? None?
I do, kind of.
You do kind of. Where are you, Amelia?
So I'm like 40 minutes from like a hospital, and then like 30 to an urgent care.
Okay.
And I drive like an hour to take my kids to their doctor's appointments.
Oh, wow. All right. So you live it firsthand. And so have you seen any work in the rural community that is going to be helping to make that access to healthcare any easier? Because this is a big push in America right now.
I've seen more people like resources that will drive out to your house now that a couple of years ago we didn't have, but now like when my kids need like speech or something, they'll come to us.
Good. And so you have that availability a little more so, and that's important. So things we should think about and look at. Amelia, are you planning on staying where you are?
Yeah.
So where would you get a job in rural healthcare?
So I am an LPN in a facility, but I have to drive an hour. There are nursing homes around us, but they're still like 20 to 30 minutes drive.
Mm-hmm. So when we think about our rural healthcare providers, this is something to think about. They're living among this, and they're far away, and they don't really have choices, right? So this is why physicians sometimes are not going to want to do that. Nurses are not going to want to live in these rural communities. The hospital that's closest to you, what level is it? Is it like what level intensive care is it?
I know they don't take severe cases. They send us to Columbus. I went into early labor with one of my kids, and they sent me like an hour away in an ambulance. Yeah. So they don't take high tiers. I know a lot of times if I take my children to that hospital, they automatically send us to the children's hospital. Like they don't even usually try to see children.
Right. Yeah. So that's a big concern. But do you see a lot of homeless in your community?
Actually, yes. We do have one guy that walks up and down the one road that goes into town every day. You see him walking.
So you see one that's the other thing is, if you become homeless and you're in a rural community, how are you going to get out of there? I mean, transportation's a problem if you don't have family somewhere, right? So these are all things that we can apply just from our one classmate's experience in a rural community, right? She can't get anywhere. She's going to have to work an hour away, and probably the pay at the one that's closer is less than the pay further out for a more acute facility. So things to think about all over with healthcare in rural communities and our homeless population. All right, we take a look at our next topic, which is going to be Medicare and Medicaid. What do we know about Medicare and Medicaid?
That it's government funded.
Good. Both of them are federally funded. Yes. One is run by the state and one is run by the U.S. government. Which one is run by the state?
Medicaid.
Good. Medicaid. The way that I always remember this is that depending on what state you live in, it has a different name. So like in Colorado, it's like Medicaid for kids is child first, or what is it in, where else are we? Where is it in Ohio? Rachel, where are you?
I'm in Florida.
Florida. What's it called in Florida? Do you know?
No.
Or the kid care.
Kid care. That's another one that I've heard. Yeah.
Healthy families.
Healthy families, like all that. So they all have different names. And Medicare is going to be for our who's Medicare help?
65 and older.
65 plus.
Good.
People on disability.
Yep. So we're 65 and older and our disability. The way to remember this is the word Medicaid has the word aid in it. So it's giving aid to those that need it. Okay. So who are the people that are going to need help with healthcare?
Low-income families.
Very good. Low-income families. Who else? Who has no money to buy insurance and wouldn't even think about it?
People with disabilities.
Sometimes it depends. It'll depend on what the disability is, but yes. But who is a population that we know of that doesn't make any money, doesn't even know what insurance is?
Homeless.
Children.
Yeah, I was going with children there, but our homeless may not know, but kids have no idea even what insurance is. I bet if you asked, I mean, even if I asked my 16-year-old, I don't even think she knows what insurance we have, right? They just don't think about it. So think about these kids that don't have the ability. I don't know if anyone's worked in the Medicaid population, but I have for many years. What kind of things do we see on the kids that are not getting health care? What organs are affected by it?
One is their heart.
Tell me a little bit why you think the heart.
You're right. Obesity.
Good. Obesity, we tend to see with low education, high poverty, we're going to see obesity. Why is that?
Because they're low income and their parents probably aren't even educated.
And so low income does what with our foods?
They buy cheaper foods that last longer. They buy the highly processed foods, which is going to make children gain weight.
Right. If anybody's been to McDonald's, and I only go there for the diet soda because I like the fountain soda. But when you go there, if you look, there's like a $3 meal. I mean, if you can feed your family for $3 for a meal, does it really matter what the food is? I don't think anybody thinks about it. And if you go to some other fast food, anybody have Chick-fil-A by them? That's the healthier version, right, of fast food. But it's way more expensive. It's expensive. You pay about $20 for 2 people at Chick-fil-A. So that's a lot of money as compared to the $3 meal at McDonald's, right? So think about that impact and our lack of education and our availability and vegetables. If anybody does anything in the supermarket, if you do the food shopping, you know, vegetables are always going to be more expensive than the flour, the salt, any of the basic products that you could use. And so think about that. It's high carb, high fat, right? Is the kind of foods that we see there.
I live in Pensacola, and in my community, there's a farmer's market where on Sundays they have these little green buckets, and you could fill it up to 4 pounds of produce like vegetables and fruits, and it's $6 per bucket.
Oh, that's wonderful. How's the produce? Good.
Yeah.
But see, that's something you know about, and that's an educational thing, right? You're like, I'll go to the farmer's market and get my fruits and vegetables. Think about somebody with a language barrier who doesn't even know what a farmer's market is, because if you say the word farmer's market in Spanish, it probably doesn't mean the same thing to them as it means to us, right? So very good, though. That is an asset, and that's something in your community. If I were you, I would promote to everybody, because it's an easier way to get those healthy vitamins and, stuff in, and people may be more likely to eat them if they have them and they're not super expensive, right?
I tell everybody I know about it, and especially my patients in clinicals that I know are like malnourished and they're not eating properly. I always tell them about it.
Very good. One big difference also with our Medicaid and our Medicare population, one of them is not going to reimburse for nursing services. Does anybody know which one? Medicaid. I'm sorry, it's going to reimburse. Sorry. Which one is going to reimburse for nursing services?
Medicare.
Fully? Yeah, Medicare is going to refund or give back or pay for nursing services in the home, where they will not refund, and they will not, and if anyone has older parents or has taken care of older people, they will not have somebody come into the home and help them go to the bathroom, will not have somebody come into the home and pay for them to help them get changed, to cook food for them. So all those like basic non-nursing duties, Medicare does not cover. That creates a problem. Let's think about it. You're an older patient, you're by yourself, you have Medicare, they don't cover activities of daily living. What's that going to do to our older people?
Their loss of independence, and they'll have to go to like a nursing home or falls.
Good. They're going to be way more susceptible to needing that, right? Needing the help with activities of daily living. And as a federal institution, we don't cover that. And does anybody who's been, most of you guys are LPNs, but you know, like home health care is super duper expensive. Not that the LPNs get paid enough, because I know you guys don't, but those companies charge a ton of money. So you're asking a client who's retired, potentially with no income and needs help with activities of daily living. Who are we going to rely on for these people? Who are we going to look to help support them?
Their family.
Good. We're going to really reach out to families. Problem is with families is some of them don't want to deal with it, right? And we know that. What do we see among our older population? It's a #1 risk factor for them from families.
Abandonment.
It's actually abuse. But yeah, abuse, abandonment, it's the same, you know, they're abandoning. So what ends up happening is these people are relying on their families then are turning around and abusing them financially or emotionally or mentally, and then they're at a standstill. They've worked their whole lives, and here they sit at the end of their life being treated that way. So just something to really think long and hard about when we're going into these homes with these older patients, or we're taking care of them in facilities. A lot of them are just really lonely, and you know, that's something that we want to be particularly sensitive to, right? All right, so we talked about Medicare and Medicaid, which was good, and you guys seem to know a bit about that, which I'm happy to see. And then we have a chapter that talks about parish nursing, right? That was this week's. Anybody familiar with parish nursing before you read the chapter? No? Before I started teaching community nursing, I didn't know about parish nursing either, so that's why I always ask. So it's a field. Has anybody ever known one? Because I had a student, the new one. Her sister was one. So parish nursing is going to be somebody who works in the community, in a parish or a temple, or, you know, a mosque or whatever. So what do you think is important for parish nursing? What are some qualities that you would look for when if you're thinking of becoming a parish nurse?
Religious.
So it's funny, not funny, but interesting you say that. So what I will present to you is this, is that they just need an awareness, okay? They don't have to be religious. They don't have to believe in the faith, but what they have to be is educated about the faith that they're working among, okay? So students have had a hard time in the past, and there will be a question on your tests potentially about what, in a Catholic church, does the nurse have to be Catholic? Absolutely not. What the nurse has to be aware of is the practices, the beliefs, the traditions, how do you think you could find that out? How could you find out about a community?
Evidence.
By touring the community.
Do what, Sonia?
By touring the community, like involving yourself in activities, taking a look around, going to playgrounds, involving yourself like within the community to learn about it.
Good. You're going to immerse yourself in the community. Absolutely. What else are you going to do?
You could ask them.
Absolutely. You ask, like, what are your traditions? What are your holidays? What's your normal diet? What else are we going to do?
Research.
Yeah, absolutely. Our evidence-based research, we will, of course, use that. But also remember, you can always read about it, right? You can make sure that you're visiting people's homes. What are things you'll look for in a house when you're visiting and trying to assess their religious or spirituality? What are things you see?
Religious relics that they have hanging.
Yeah, sure. Things on the wall. What else? Here in Colorado, we have a large Mormon population. What do you see when you walk into a home that practices Mormon practices? It's their book. It's their Bible. That's what is right in their front door. As soon as you walk in, you know that. So that's a good giveaway. You could read through that, figure out what kind of practices do they follow, right? What other things might tell us a little bit about someone's spirituality?
It's the way they dress.
For sure. Tell me a little bit more.
Like your apostolic faith, like some of them they only wear dresses instead of wearing pants. Like Catholics, is it Catholics that wear like the little yarmulkes on their heads?
Jewish people.
Jewish people, yeah, they wear yarmulkes, so you'll know.
Good. The Jewish faith, they have specific things, some depending on where they fall on the spectrum. Some women wear wigs, some women will be covered, the only person that can see them is their husband, so it's something to think about with them. Muslims, we talk about they wear the hijab, right? So that's a dead giveaway to us when we see somebody that there is something there that we as, Americans not practicing that faith don't oftentimes wear. We could, but so this is another giveaway. Their clothing is a big, big, big thing. What's something that people wear? It's very symbolic.
Cross.
Laura, you just did it. Yeah, necklaces, right? They wear, either a Jewish star or a cross or Buddha or, anything that they're going to wear. So you're going to look at that. And those are kind of things to lead you into this is their faith or spirituality. So just be careful as parish nurses. I'm going to show you a quick video on one, and you can see how much of an impact they have. This week was parish nursing, home and hospice healthcare. I don't spend a ton of time on home and hospice healthcare. But we will talk about it a little bit. So let's take a look at this video real quickly, and then I will, just so that you guys get a taste of it. Like I said, part of it is too, because I have not had the experience to practice with a parish nurse, so I would love to, but that's why I always ask people if they know anybody.
Sharon Clohesi's world was turned upside down by one phone call when she discovered she had both a hole in her heart and breast cancer. Unemployed and uninsured, James Dobson's high blood pressure was life-threatening. Shortly after Karen Houston's husband suffered a nearly fatal brain aneurysm, her daughter was diagnosed with diabetes. Unable to sustain her oxygen levels, Lily Giacchetti spent more than 1 month in the hospital. Though these people were dealing with devastating illnesses, they did share one advantage. They each turned to their parish nurse for support. Across the country, parish nurses practicing the specialty of faith community nursing are improving public health by reclaiming the historic roots of health and healing.
This is your bubbler. How often do you change the water?
I have to change it every day.
When Mrs. Lily Giacchetti was hospitalized for nearly a month, parish nurse Ramona Davis made daily visits.
My illness was really serious, and everybody knew it.
I visited with her. I followed up and explained a lot of tests that she was required to get that she really didn't understand. When she was ready to be discharged, I made sure she had her equipment, she had visiting nursing, she had her oxygen set up. 128/70, that is really good. You are doing such a wonderful job.
Yeah, that's right. There are a lot of churches in our neighborhood, but there's only one parish nurse. And people will come in, they'll leave other churches and stop by to see Ramona.
I wonder how in the world I could have done ministry without a parish nurse.
So I'm going to give everybody a handout.
Ramona's duties range from assisting the critically ill to supporting church activities and promoting wellness.
I do a lot of health teaching with the kids from the school and the confirmation kids at the church. So we're going to look at it from a religious standpoint. We currently have a gospel aerobics class, which is intergenerational. We get to interact with people on an everyday basis. If there's a change, you notice it.
How was your blood pressure the other day? Okay.
It was 135 over to 85.
Oh, goodness. We have these long relationships with people. Okay, take a deep breath. I've known some of the people that I care for now a good part of my life because this church is where I was raised.
These long relationships.
I'm going to pause it right there. So like I said, and I want to re-emphasize this, the woman in this video is part of the church community. That does not always have to be the case. So just please be comfortable with that, knowing this woman is part of the community. So she's known these people forever. And that's the only part of the video I don't like, because that doesn't necessarily have to be the case. Okay, just understand. Sometimes it is, sometimes it isn't. So just wanted to give you a little taste of parish nursing there. You saw how much she does, the first nurse does for the community. And this is where we see it in community nursing, things that we can do, exercise classes, education to the kids, education to older people, visiting them in their home, right? How many of us do home health care currently? Rachel, you stand all alone, huh? Just you? Oh, you can share with us good stuff. What are some things, what do you do in the home? What age do you work with?
I am just private, so I don't really have much experience, and she's 99.
Oh, wow.
She does everything by herself. I just have to just make sure like she doesn't fall and stuff.
How long are you with her? Like every day or every other day or what?
2 days a week.
2 days a week. You work for an agency?
No, private.
Oh, independent.
Yeah.
How did she find you?
Through my aunt, who also works private.
Interesting. Yeah. So in the home, this is where we talk about home health care and home nursing. We only have one. Usually there's a bunch from home health care. But anyway, so Rachel can help us because she's an expert on this. And so what are some things that we look at when we're going into someone's home? When we are a nurse in someone's home, what is our priority?
Carpet or like rugs.
All right, interesting. And why are we worried about rugs and carpets?
Safety, falls.
Good, falls. We are also always worried about, and as nurses, this is something we have to be very conscious of, our own safety, correct? Rachel's in a house with a 99-year-old woman. That doesn't mean Rachel couldn't go into the house and have a 40-year-old in that house, right? Who's going to do some things that maybe Rachel isn't too fond of. Who knows, right? So we got to think about safety. What are some safety techniques that we use in someone's home?
From what the book said, you could, when you're sitting in the house, you could sit right next to like the exit.
Very good.
Not enclosed.
Good. This is coming straight out of the book. Good job, Rachel. What else did the book say about safety in the home? There's a whole list. I'm not putting pressure on you if you don't remember. It's okay. We want to notify somebody, right, when we get there. How about our clothing? What kind of clothes are we going to wear to somebody's house? Our best clothes, our worst clothes?
Hopefully our work clothes, like the scrubs or whatever.
Good. You want to wear something that's comfortable, right? But you want to be professional. So you don't want to wear, you know, a tank top, or like all the teenagers now. I know I sound like an old lady, but they all wear these tank tops that are half shirts, and that's all they wear, and then tight pants. And so you definitely don't want to go to someone's house looking like that, right? We know this, right? Even if it's in style. What else are we going to be careful of going into someone's home?
Would it be like the time? I can't remember. I think we had a question like that on the test, and said something about picking an appropriate time or availability or something like that.
Yeah, so when you're, I think that was about for planning the care, but you want to make sure that you are not disclosing too much information, because what ends up happening to people is that they get uncomfortable sometimes. We also have to remember we're walking into someone's home. I don't know about you, but I'm pretty proud of my home. And it's rare that you'll find someone that isn't proud of their home, regardless if the home is a 1-bedroom studio or a 4-bedroom mansion, right? It doesn't matter what the home is, it's their home, and that's their their place of peace, right? So when you go into their home, you got to be really respectful to whatever it is you see, whatever is going on, the dogs, the cats, the mouses, the whatever, right? We see running around. This is why I would never do home health care, because I'm too much of a scaredy cat to be in someone else's home. But you have to be aware that people live very differently, and you don't know what you're walking into, right? We also don't know the families. What's something that is in people's homes, and whether it's illegally or not, who knows? But it's in someone's home that could be pretty detrimental to us as nurses visiting in the home.
Gun.
Absolutely. And it's more and more popular now for people to keep them out so people see. So, you know, something we have to think about with our safety with gun violence. We want to be very careful not to say anything in someone's home about our beliefs or our politics or our anything, right? Because that's not for us to do. That's not our job. Our job is to take care of them. So, and in the home setting, it tends to get a little more flexible because it's their home. So they feel like they want to show you everything they have, as opposed to being in a hospital or in a nursing home. They don't have everything that they have at home. They want to show you pictures. They want to show you books. They want to tell you about their, you know, families or their neighbors or whatever. So be careful with us for safety. It's just a big one with home health care. And to realize that these are people's homes. And so we want to be extremely respectful to them and to their beliefs. With that, what are some things that you might see in a home that would make you uncomfortable?
Needles lying around, like if they're diabetic and they are using insulin and they're just leaving their needles lying around instead of disposing of them properly.
Good.
Maybe someone who you weren't expecting to be there.
Mm-hmm. About bugs, because that would make me uncomfortable, but you have no idea what makes everybody float, right? So could have bugs in their home. What's something else that we're going to see in a home that's going to possibly be of concern to us?
I'm not being very clean.
Good. Dirty.
Unkept pets.
Good. Unkept pets. With that, there's unkept children too that you might see, and it's in their home. And so just some things I like to put out there for you guys to have in the back of your head when you're going to someone's home. These are some things that could make someone uncomfortable, but we're nurses, we have to care for them. So we have to not put blinders on per se, but just realize you're only going to be there and then you leave. And so you have to respect them and their boundaries, just like, you know, they should respect ours. That doesn't always happen. But, you know, you want to be the professional, and this is really where we go with home health. Takes us into hospice care, and I will tell you this. I have personal experience with hospice care with my mom, and so it's a very hard topic for me to talk about, but she was only on hospice for 1 day. So, but I will tell you that woman who came into my home, that nurse that came into my home, made that day, a very hard day for me, made it the best she could. And I apologize because it's still hard for me to think about, but you know, so hospice nurses are amazing people. They have a gift. What do you think their job is as a hospice nurse?
Comfort, like the support for the family. And I could understand what you're saying, because this is the 99-year-old, she's not the only one who I had other people, and I remember I had like a friendship with them. Mm-hmm. And then when they go onto hospice, like you could just feel the death in the air, and you just like, you know, although I'm there, I'm taking care of them, I still feel really, really sad. Mm-hmm. And I just remember how I felt when the hospice nurse came. It was just, although she was just there for a short while, I just remember how uplifted I felt. Mm-hmm. So I think their goal is providing support for the family and for the mm-hmm. client.
And they really give dignity to that person. And anyone who's had experience with it, I hope you've seen that, because that is their role, is to give that dignity at the end of life for whomever that is, right? And so they do provide comfort care. They will give morphine as a comfort. But they have to be extremely comfortable with death and dying, because that's all they see. So, you know, that's just something to think about with hospice. Like I said, I don't spend a ton of time on hospice because we're going to be worrying about the same kind of stuff, that we're giving our dignity to the family. Everyone deals with death differently. So while some may be very emotional, some may be very quiet, some may be very loud, some may be, you know, not happy at the thought, but maybe relieved that the person is out of pain, out of discomfort, out of whatever they've gone through, right? So just be real careful with hospice. If you ever see a question on it, the goal of a hospice nurse is to give dignity to those around them. And that is just the ultimate thing that they can do. And they are extremely wonderful people and have a gift that have a gift. And so just think about that. It's a big field. There's a lot of offerings in that field. And I think because what ends up happening is people wear out. It's trying on them emotionally and physically. And so they get tired, they get tired and they want to do something different. So just something to think about. Anybody interested in hospice nursing? Rachel. Yeah. I mean, I admire that.
True about people getting tired.
I'm sorry?
It's so true about people getting tired.
Yeah.
Burnout is real.
Right. It's very draining, it's just emotionally, physical, all that. So things to think about with hospice care. Trying to think what other topic we would cover with hospice. All right. So we are at an hour in, so I'll give you guys the opportunity. You want to break or you want to go out 10 minutes early? Raise your hand for a break. Okay, we'll finish 10 minutes early. Okay, we are going to, for the remainder of the class, I emailed you guys a case study. I'm going to break you out into groups. There's 3 questions that we ask about the case study. I'll give you a little bit of time to go through that. And so just check your email. You guys should have gotten that like a minute or 2 before class. And you're going to go into breakout groups and we're going to answer the 3 questions that are on there. What I would ask is one member of the group to do like either a Word document or a PowerPoint slide or something, just so when you guys are presenting your answers, we can all see it. Okay. Everybody understand? Did everybody get the case study? Good. Great. Awesome. Okay. So I'm going to break you up into groups. I do it sporadically. So hold on. Let's do that. And how many are we going to do? Let's do 4. Okay. So there'll be about 5 of you in each room. All righty. Here we go. Oops, I have to open them. That would be helpful, huh? Okay. Michelle, I see you say you don't have it. Oh, she left. I'll have her.
Trends. Oh,
Yeah, we're slowly coming back. If I
Recording in progress.
Am I like kicked?
You're back.
You're back. Okay.
All righty, so we had this case study that we all took a look at, right? And we did some thinking about the questions that we had here. And so our case study really was interesting because it talked about homeless and it talked about a shelter. And we know women and children are always of concern, right? And so they found that who has more risk of who has a higher homeless population? What group of people?
Women and children.
Good, women and kids. So, and this we know. So what ends up happening is they open the shelter, and what we were thinking about in our questions is what did we see happening with these planning for the shelter? I'm going to have group number 1 start sharing their screen. So hold on, let me do share simultaneously. And we're going to take group 1 is going to do question number 1 for us. And question number 1 was what kind of condition, what common health problems should the nurse and the task force be aware of? Okay, so that's our question that we're answering. Group 1, you want to share whatever you have.
I don't know what group I am.
You were 4.
Okay.
Group 1 was Caitlin's group.
So common health problems that we were talking about among women and children would be lack of prenatal care. So then that can lead to issues with the infant, which is what we talked about, like low birth weight, preemie babies. Then they all have their issues. Another common would be very communicable diseases, because they're just, you know, if you're homeless, you kind of just live around a lot of people and you don't have your own personal space.
Good. What else are we going to look at with them? Anybody can help. What kind of conditions are we going to see?
We can see lead poisoning, like we had spoken about. We can see
about infectious disease, right? We know that that's a problem. What kind of infectious diseases are we worried about?
HIV.
What else?
Hepatitis. And then also there's the ones that aren't transmitted through bodily fluids, like MRSA.
There's one that has 2 letters.
TB.
You got it. Yep. TB is another big one there, right? Some health problems that we look at. And when we talked about this in one group, it was saying that the healthcare problems in our vulnerable populations, regardless what that is, women and children is the one that we speak of here in poverty, but you're going to see that overlap there, right? What other kinds of concerns will you have with our homeless population?
Well, we had injuries from domestic abuse, substance abuse, mental health, and suicide.
Good. Mental health is a big one. We really got to worry about that. Abuse is another one. Alcohol and drug use is a chapter that you guys had last week. We didn't spend a ton of time on alcohol and drug abuse, but what do we know about alcohol and drug use? Just share a little bit of information. What do we know about it?
Drug use, they probably share their medications. So they'll share needles, dirty needles.
They might. What other kind of meds might they share? Anybody who, go ahead, what, Courtney?
Any of them, like
Mhm.
pain medication, or anything that they might think that they have problems with, maybe.
Think about our teenagers too. What are they sharing?
Their prescription drugs.
Absolutely. ADD, ADHD meds, big one. It's on the market for our teens right now. All right, so that was question number 1. Good work on that. Question number 2 was about specifically teaching to our children, I think, right? Yeah. So group number 2, why don't you share what you guys thought? What are the effects on the health of children?
Well, we had malnutrition, higher risk for infection or illness, developmental delays, mental health for them also, premature birth, infant mortality rate.
So
low
everything.
birth weights, right? Everything. Nutrition, we worry about, right? With kids that they're not getting nutrition. And I want you guys to think about that with our homeless teenagers, that they're probably not getting the prenatal care. What kind of things are we going to see with an outcome of no prenatal care is potentially out there? What kind of things are we going to see? If somebody has no prenatal care, what are things that may not pop up that we should traditionally know about?
Hypertension, diabetes.
Yep. And for our babies, we're going to see what?
Rh positive or negative.
How about our birth defects, our cardiac on our babies, right? And what ends up happening when, has anyone done any time in the NICU? You guys clinically, right? You visited, haven't you, or no? Yeah. Did you see there our babies without prenatal care? Did you see many of them? So you're going to see those pretermers, and they're probably going to have maybe some addiction happening there, right? So all this is happening. So when we talk about kids on the spectrum and homeless, we really want to talk about the entire thing. Our third question, anything else you guys want to add? Michelle, you were pretty thorough on that one. Anybody else want to add anything on question number 2? All right, question number 3 is, what are we preparing for as the nurse? So group number 3, what are we preparing for as the nurse for this population? Group number 3, I think you were Mia's group, maybe? Mia, were you 3?
I'm not sure what number group we were, but for
We
that
were
one,
2.
were we?
Oh,
Okay.
okay.
Well,
Then she already answered, but help us out, Mia.
so for that, we had the strategies would be like mainly respect and just showing them like basic care and concern for their issues.
Good. So compassion for them. This one group spoke very clearly about respect for them and how important that is. And like I shared with them, and as you guys have probably witnessed, homeless people don't want to be in that situation. They don't. So they're not happy to be there. And poverty is not something that anyone would ever ask for. So think about that and our compassion as people. We're not just nurses there to help. Courtney, what did your group have for question number 3? Because I know you were group 4. You're muted.
We had not judging them, assess for their education level and reading level, give them resources, help with a Medicaid application, or even like a food resource application, transportation, and communicate at their levels, give them as much pamphlets if they're able to read.
Okay, good. What else can we give them if they can't read? What do you give them if they can't read?
Isn't it an audio version?
Audio or pictures? Pictures, right? And we want to know, we want to create that trusting environment, right? So that they share with us what they're going through, give them as many resources as we can, right? All these good things. All right, well, I'm glad you guys did very well in that case study. Let's just take a quick look. We have 2 minutes left. We'll take a quick look at what's due this week. Any questions on what's due this week? We should be working on infectious disease. I need you guys to give me your infectious disease by the end of the week, I think is what I said in the announcement. So you guys are just picking one. You'll be doing a paper as a group, week 7. Okay. And then week 9, you're working on your vulnerable population. So this week, we don't have a ton of assignments, but I want you to be working ahead, okay? So that you guys aren't overwhelmed at the end. Infectious disease paper, just one side note, please do not cut and paste off the internet on them. They're pretty easy to figure out, you know, when you cut and paste off the internet. So just make sure you use your source and use the internet as your help, but put it in your own words so that we can all understand it. You guys will be presenting a little bit about your infectious disease week 7, excuse me. Anyway, we have next week class, regular time scheduled, and then we will have our exam that following, and study guide will come out to you. And if you guys don't get it by next class period, you'll let me know, okay? So that we have a full week with it. Any questions? All right, guys, have a great week. Oh, go ahead.
Recording along with the PowerPoints you used in this lecture under the announcement.
So I can't show the PowerPoints, but what you can do is if you I think I can. I have to ask Dr. Lundy.
Okay.
But if I can, I will post it for you. The other way to look at it is I'll just send it if I can.
Okay.
Thank you.
I can't share videos because PowerPoints because they're mine, and so they're not copyrighted, so you can't share them. It's a weird thing. But anyway.
But you can post the recording.
Yeah, the recording.
Okay.
Okay. Any questions that you guys have other than that? Let me just I'll text her right now and see if I can do it. And other than that, all right. Take care, everybody. I have a meeting after class. I'll stay on.
I do have a question for you.
Sure.
When I was doing the discussion for last week, I went on to reply around, I don't know, maybe like 8 or 9. The replies were closed. I didn't get to post my replies to anybody. I thought I put it in that email that I sent you, but I went back and looked at it. I didn't notify you.
So the posts were all done. Dr. Lundy and I checked the timing and dates of them. So that's weird because they should have all been midnight. We did 11:59. So when I post times in Canvas, sometimes they don't convert properly. So I went over it with her and had her double check. So I don't know why that is, but I
know that there was another person, maybe like Tiffany in the class too. She tried to do the same thing, and it was well before midnight that when I tried to do it, and the replies were closed, so I didn't get to post my replies. To anybody.
Okay, so send me an email with 2 replies. That's all, and I'll give you credit. I think I'm meeting you, aren't I?
Yeah.
Okay.
I wasn't. Yeah.
Just hold on one second. Just hold on one second, okay? Because I don't want to disclose information. Rachel, you okay? You're muted. Only because I was muted earlier, so now I hear when you're talking.
I think our message said, "Oh yeah, we can meet after class this week about."
Okay, yeah. Don't worry. So hang tight.
I'll just email you because I have a PEDS exam to go to.
Oh God. Do this? Yikes.
Yeah.
All right. Good luck. Just email me. Okay. Bye. Sonia, you okay?
Yeah, no, I just wanted to talk to you about an email that we had going back and forth, and I just wanted to make sure that you received the document.
Yeah, okay. So hold on, I'm gonna put you in a breakout room, we'll have this conversation. And so Rachel, just hang tight, okay?
Okay.